Carey.
My lady, thank you. Mrs. Whately, can I ask you please briefly about changes to the regulatory inspection regime? We know already, of course, that routine inspections were suspended in March of 2020, and I won't revisit that decision with you. And I think you certainly say in your statement that you recall receiving general updates on the emergency support framework that was put in place as a way of trying to remotely monitor risk. Mm-hmm. And you were having updates in relation to that. And I'd like to jump forward, please, to the 1st of July meeting that you had with the CQC. Before we go to the meeting, though, I think to help you, on the 11th of June, there'd been an update saying that there'd been over 5,000 emergency support framework calls that had taken place. Mm-hmm. And you were recorded as stating that you didn't feel there was visibility on what interactions are being undertaken by the local authorities or the CQC to ensure that there was safe care going on. You said, I feel I've no intel, no idea what they found out. It's a black box or hole to you. And you felt there were significant gaps in what you'd been seeing has been done. You said that when you asked how sure that people hadn't died in care homes for neglect, you didn't have that assurance. Now, that was on the 11th of June, mm-hmm. So just a few weeks before the 1st of July meeting. And we're at your paragraph 396 onwards, Mrs. Whately, but it may be that an email I'm going to show you helps you with that meeting. And could I have on screen, please, INQ 609960_2. Thank you very much. The KT is a lady called Kate Taroney of the CQC. You were there. Now, there's a number of things being discussed in this meeting. One is an issue about data, and one is an issue about what was being done to ensure that there wasn't abuse of residents in care homes. And I'll try and deal with both as we go through. Mm-hmm. Can you see the third bullet point down, or dash down? You asked about data and information from the provider discussions on specific issues. Kate Taroney confirmed this was detailed data in each provider record, but there was main themes were workforce, PPE, multitude of guidance, discharge, and the withdrawal of the health offer from community nursing by the clinical commissioning groups. So was that things that had been raised with the CQC by providers as concerns, or was it that you weren't getting the data about those concerns? Just take.
I think that was the concerns that they had gathered from their data.
All right. And you mentioned then that insights sounded helpful, but you were not confident the reports on these had been flagged with the department, and you certainly did not see this at the time. And then following the meeting, you asked whether this information had been received by the department and whether they'd received anything other than data from the capacity tracker. If it didn't come into us, was there good reason for this, any particular barrier? You were not clear on why the CQC didn't share intel they had from inspectors' contacts with care homes with you before, as we'd asked for it, and asked if that was information, if this was due to not having a mechanism for getting the info up to Kate. So that's just one issue, mm-hmm. And I'll come back to it because it's copied late, or it's answered later in part by an email. But as we go towards the bottom of the page, you start to discuss there information in relation to what is being done to ensure people weren't being neglected. And Ms. Taroney noted cautiously that whilst the right measures were taken, and she gave an example of a care home that was closed mm-hmm. because it lacked basic safety for residents. In bold, it says it is likely we will see an increase in the number of services that haven't been able to cope during the pandemic, and therefore a spike of these cases being unveiled in the next week. And you're extremely concerned about this. You're flagging comms with the comms colleagues in case we have any intel. Ms. Taroney stood by their decision to stop the routine inspections, and you agreed, but it was still likely to uncover bad cases in the next few weeks. And you asked for more insight into CQC findings in terms of live intelligence, especially where there are known alarming cases. And Mr. Roney agreed to take that forward and share any potential actions. Can I just help you? Did you, in this meeting, get any sense of the scale of the problem, about how many cases there were going to be unveiled that had been potentially either neglectful or abusive?
No.
You clearly, though, were concerned by what Mr. Roney was telling you. Had you had any inkling, suspicion, or anything raised with you prior to the 1st of July to suggest there was going to be a problem once inspections started again and perhaps the abusive or neglectful cases were uncovered?
I don't believe so. I mean, I guess it might be helpful to step back a moment. So, Kate Taraney was CQC Chief Inspector for Adult Social Care, with whom I had a good working relationship with the pandemic. She had a background in social care. I think she was extremely competent, capable person, and tended to be frank and straight in her dealings with me and the department, I believe. That was certainly my impression. And I knew, and it was sort of by sort of agreement, or I was aware of the decision for CQC to stop their routine inspections going into care homes during the pandemic for the obvious public health reason of the risk of taking an inspector taking COVID into a care home, and they set up an alternative procedure to sort of keep an eye in the meantime. I think the first thing that you have identified and shared here is the fact that they had done these 5,000 calls or so, had gathered lots of data about that, and I just thought that looked really useful data. And in a circumstance where all the way through the early part of the pandemic we're trying to get data and get better insights, I think what you've shared is my frustration that there was some data sitting there, that why hadn't CQC been sharing it with us from the moment they were starting to collect it at any scale? Just that would have been useful.
Can I pause you there, Mrs. Whately?
You can.
It's simply because whilst we're on that point, can we have the top email on page 2, so there's no misunderstandings, because you've got the point there that why isn't this intel coming to us? We only had what was in the tracker. And can you see the answer from Ros relating to that first point in red? Whilst we might not have received it formally, we certainly did receive this feedback through the weekly national COVID adult social care calls, which Ros and someone called James Bullion had chaired. All of these issues featured heavily and shaped our policy concern. So I don't quite understand the Minister's concern. It seems exactly what we were hearing from providers at the time. Now, it may be that it's coming in from two different sources, and you were still nonetheless keen to get the CQC data and not just hear it through the weekly national COVID calls. But was that, do you recollect, that you were getting the same kind of concerns that the CQC were raising, albeit from a different route?
So yes, the concerns that were listed by the CQC were familiar things. So it's true that I've been getting that, and evidently, but I think to the extent that CQC had data which might have given us more colour on a geographical focus or to a particular type of care homes that were being affected, or something which would give further insight, I would always rather have had the greater insight than just the rolled up summarised version, which might have been what I was therefore presented with.
Do I take it that there may be a comms issue here? Because if there is this repository of data that the CQC have got, and the department, indeed the Minister, would like it, something's fallen between those two stools. Do you know, was there any protocol or plan in place for the sharing of the data that the CQC were collecting, other than that which that went into the capacity tracker?
I don't know if there was a formal protocol from the communications you shared. I mean, clearly data was being shared, but as I was then given a sort of summarised synopsis, high-level view of it rather than something more granular, which I would have liked.
Now, I interrupted you when you were going to, I think, perhaps go on to deal with, after you told us that you actually had a good working relationship with Ms. Taraney. I asked you whether you had any inkling or suspicion that prior to the 1st of July, there may be about to uncover a problem with abusive and neglectful cases, and I think you were going to address that.
Yeah, so I think, and this explains my reaction in the content of sort of frustration, shock, however I articulated it, was that they'd been doing all these calls, so why did it take until July to kind of notify me of cases of neglect? I recognised a risk of it because, as I said this morning, one of the biggest worries at the outset of the pandemic was that we would see what we saw in Spain of abandoned care homes, etc., and the risk of neglect. And I've been trying to put in place early warning systems and the capacity tracker that would tell us if those sorts of things were going on. So I knew that there was a risk of it happening, but I think this is the first time formally that I was told that they had identified cases of neglect. And given that we're talking about July, like, that feels really late. Not like, why didn't I get notifications in April, May, June, whenever they first identified it?
Did you ever find out the answer to why you weren't formally told before the 1st of July?
I don't recall.
Okay, all right. And then just to finish with this email thread, if we go to page 1, we've clearly looked at Ros's intervention explaining that the info may have been coming via a different route. And at page 1, the sender says that they have flagged with the Minister, but on the call, Kate suggested a level of detail that the Minister does not recognise. Given the Minister's real concern by Kate's admission that we should expect cases to emerge in the coming weeks of potential neglect, abuse of poor standards, she has asked, 1, is there a way we can get them to expedite inspections? Can we get more formal information from the CQC on where they are carrying out inspections? And do we internally have a sense of what the scale of the issue is that may be about to erupt? She's really clear that while she agreed with the CQC decision to stop routine inspections, she did not agree that this was done at the risk of neglect, abuse to residents. And Kate's comments today did not reassure her or you on this point. Mm-hmm. So did you ever get any information about whether there was a way to expedite inspections?
I'm trying to dig back in my memory. I mean, I think they did move, or assured me that they moved as quickly as possible as they could to restart inspections and get closer back towards a normal way of working. Though the other thing we did at some point around this time was increase the focus on inspecting for IPC, for infection prevention and control compliance.
Probably answers bullet 2, but and then do we have a sense internally of what the scale is of the issue that's about to erupt? Did you ever get any idea of what the scale was?
I don't recall getting that.
Okay. Just to finish that, on the later that day, I think you WhatsApped Mr. Hancock, and can we have up on screen INQ 274068_13? Thank you. And the entry at 12, I think 45. Thank you very much. You tell him, just so you're aware, CQC have at last shared with me info about what their inspectors did March to June. They've been in touch with many care homes and raised concerns with local authorities. However, they did not share their concerns with me, despite me requesting more info in regular meetings. There is also a material risk now they are restarting inspections. They will uncover cases of neglect. The processes put in place in March were meant to prevent that, but Kate Taroney is not confident. I've asked her to keep me updated so we are forewarned rather than seeing things in the media first, and he thanks you for that. And then, sorry, it's more potentially bad news, but I thought better you should be in the picture. I really pushed CQC to have a system in place that would pick up and stop neglect, poor care. It's frustrating that Kate could not assure me on this in my meeting with her today. Excuse me. Can you help with what system did you push for to be in place? Was it the ESF or was there anything additional that you were asking the CQC to do once they stopped routine inspections?
Yeah, so the CQC decided to stop routine inspections, and as an independent regulator that was up to them, but I was aware of that, and it was not unreasonable considering the pandemic and the need to reduce footfall. But as part of them advising me they were doing that, I said, well, how are you going to make sure that there aren't problems in care homes that you would otherwise be inspecting? I think the point was they made was particularly they were suspending routine inspections, so that wouldn't necessarily be the ones that are high risk. It was just the ones that would, as a in the normal case of things, be to identify whether to give a care home their CQC rating. And then they put in place this emergency support framework that was intended to be an effective way of remotely monitoring places that were higher risk. And at the time I said, no, is that going to work? How will you make sure, given the increased risk in the event of the pandemic of neglect, how will you make sure that avoids that identifies that? And I believe at the time of that conversation, I was reassured. And then in July, late June, July, Kate Taroney is telling me, actually, there are going to be cases coming out that we haven't managed to pick up. I mean, to be fair to her, she is at this point being straight with me and not attempting to cover up that. She's given me advance notice that that's what's on the way, but it was not very advanced, felt quite late in the day. And as I say, I was then disappointed that the emergency approach hadn't succeeded in preventing that.
Can I stand back from the detail of that and just ask you this? You mentioned there, obviously, inspections are ending up going in particular to check that IPC measures were being implemented. Do you think perhaps that there is even more need in a pandemic, notwithstanding the transmission risk, for CQC inspections to continue to ensure that IPC is being properly implemented, given its importance, particularly if there might be an absence of testing? We might not have limited staff transmission. There might be not the amount of PPE that we would otherwise like.
Well, I can see the argument in future, as there was at the time, for the ones that the routine which a care home or care provider is only going to be inspected every so often anyway to do their rating as whether they're good or requires improvement or whatever. And it might make sense in the future, as it did in this, to deprioritise doing those, because those aren't triggered by a particular concern about the care home. And everything is going to be different probably in the care setting during a pandemic anyway. So are you even going to get a fair sense of how you should be rating a care provider in that circumstance? However, what you do need is to have an effective way of identifying where a care home is not coping, is not doing proper infection prevention and control, where there is neglect, particularly, I mean, with the risk of staffing pressures, and if it happened again, if you ended up limiting visitors, I would hope that we'd find a better way in future, but you can't say never. And because visitors are another way of essentially sounding an alarm. And so I think it is important to continue those kind of risk-based inspections if you can possibly find a way that is, in essence, safe to do so. And you are going to encounter the question, does it make sense if you've got a highly infectious pathogen for somebody to be going from one care home to another care home to another care home to another care home as an inspector? You clearly need testing PP or whatever it is to avoid them being a person who... And I remember even people talking in the early days saying before the inspection was stopped, that the CQC inspector would come and they blamed the inspector for bringing COVID into the care home. So that was a material and legitimate concern.
Do you think now the decision to suspend was still correct? And if you were asked in future, would you stand by that decision and indeed recommend it in the event of a future respiratory pandemic?
I mean, I don't think I have anything different to say to which I just said, which is, to some extent, it's dependent on the circumstances, the nature of the pathogen, what are your options, and where you clearly do want to have a way of keeping eyes on. But I mean, also in the future, we might have different ways to do it, including being able to use technology more to keep a closer eye.
What, a virtual inspection or something?
Variants. I would be open-minded about what might be possible in years to come.
Running through that email that we just looked at was an issue about data. So can I turn to that as a sort of broader topic, please? Yep. And in your statement, you say at your paragraph 66 that there was insufficient data at the start of the pandemic about who provided social care and in which settings, and indeed data about COVID cases in social care settings. And Mrs. Whately, if it helps you, we've discussed data with a number of witnesses now throughout the public hearing, and I dare say we'll continue to do so until it ends. You say there was initial lack of data, none of it in real time, and certainly by the, I think, 27th of March, no data on deaths, although there was SITREP data on care homes reporting suspected cases. And is that, broadly speaking, a fair summary of where we were at the beginning of the pandemic?
Yeah, I mean, there was a terrible lack of data, including the department not having a data set on care providers. CQC had a list of registered care providers, but obviously not unregistered, and the department didn't even have that. We relied on CQC for that, and it was incredibly frustrating in the early days where I was receiving anecdotal reports of deaths in care homes, and it was in the media, but had no reliable data coming through formal sources to me about the scale of the problem.
Yeah, I think you described it in your statement as you felt we were operating in the dark about the extent of the pandemic in the care homes. We do know that by the 17th of March, when the NHS England discharge letter was sent out to the NHS trusts, that there had been 86 outbreaks reported, or suspected outbreaks reported to Public Health England. Do you know whether data on the outbreaks was factored into the discharge decision at all?
I do not know, because I didn't even know about that discharge plan going out on the 17th of March. So no, and I don't know whether I'd seen or was informed of that outbreak data either.
All right. Can I ask you about data about deaths in care homes? And I think you say at your paragraph 86, you received the first SITREP data slides for adult social care on the 9th of April 2020, which included a new slide on CQC death notification trends. And in particular, there was a distinction between the CQC notifying or being notified of deaths in total, which had to be done, but then being able to disaggregate it to work out what was a COVID or may have been a COVID-19 death.
Yep.
And can we have a look at the SITREP data for the 9th of April? It's INQ 565, thank you very much, 864. And there is a comment that puts the slide in context, which may be important. Deaths in care settings are not all reported to CQC on the day that they occur. This means that whilst most are reported quickly, it can take up to 10 days for a final figure. We've now adjusted our data feed from the CQC, and our reporting includes deaths that are not reported immediately, and it's revealed an increase in deaths for most of the days in the last 2 weeks. An apparent decrease in deaths in the last few days on the graph are probably due to a delay in receiving notifications. And if we go to the next page in the slide, perhaps not hugely easy to read, but one will easily be able to identify the huge peaks. Yellow is 2020 data, and the other colours represent the preceding years. And if we look at the box on the top left for care home death notifications per day in England, first 100 days since the start of the year, so we're just at the end of March, thereabouts, we can see a significant spike in deaths in care home notifications, up to nearly 800 a day, thank you. And if we look at the bottom box, which deals with domiciliary care deaths, again, although the numbers are not as big, they're still approaching 100 deaths per day. Again, a significant spike on the preceding years. And do I take it this was the first time you'd seen data coming to you in this format and indeed in this level of detail?
I believe so.
That's certainly the tenor of your statement. And if we could just screen out again, you can see it covers the different regions. I won't go through them all, but if you look at the yellow lines, significant spikes, particularly in London. And again, for both care homes and indeed domiciliary care deaths. And perhaps some spikes, but smaller ones nonetheless, in the bottom of the row. A relatively big one there in the northwest as well. Thank you. And after you having been seen or shown this SITREP data, I think you messaged Mr. Hancock about it. And can we have on screen INQ 274068? Underscore page 8, please. And in the 21:20 that evening, You say, I'm afraid I've been sent the first proper data on care home deaths just now, and it's not good. speaking to Public Health England, CQC and Ros tomorrow about it. He says okay, but it looks like he's doing a press conference on the afternoon of the 10th. Care home deaths data may come up. We expect official ONS data on Tuesday will show a big jump in deaths. Also, we now have data on deaths of residents in care homes, but there is some double counting because it may include people who've died in hospital and not COVID. It's complicated. But it looks like this really is quite a significant day as far as understanding the death data that is now available. Can you remember whether the SITREP data as it progressed began to include the precise location of an outbreak and perhaps the numbers of residents and staff who'd been infected? Clearly it didn't as at the 9th of April, but did it get more developed as the pandemic went on?
Significantly later on, we had that kind of data. So through the capacity tracker and the Palantir dashboard, I was able to see down to the level of a specific care home if it had an outbreak and how many people had died and staff and resident positive tests and things like that. So later on...
The dashboard was rolled out on the 1st of October.
Yeah, exactly. So it's much later.
Yeah. Following the publication of this data, Matt Hancock's private secretary noted in the run-up to the action plan, which was on the 15th of April, he said it should include statistics on the spread of disease in care homes, and you'd had an exchange with him about death data again. And you were said to have been worried about knowing something the public don't, and that our science isn't taking account of a higher rise in COVID deaths than reported. In what way did you think the science wasn't taking account of a higher rise in COVID-related care home deaths than was reported?
That is hard for me to say. I mean, I know around about this time we were having a back and forth about asymptomatic transmission, and I'm concerned that there is such a thing as asymptomatic transmission, and I'm pushing for testing of people even though they're asymptomatic and being told test doesn't work unless someone has symptoms. So it may be that I'm drawing a link between what I was doing there and the death data, but I am, that's a sort of me rationalising it rather than recalling.
You've mentioned now a number of times the capacity tracker, and I think clearly the data issues were well known across both the department and indeed other departments. But you said it did lead to the development of the adult social care capacity tracker, which, as I understand it, was a tool that had been in use in some parts of England and was adapted then for a wider rollout. Does that accord with your...
Yes, so around that time I'm talking to Ros, and I had a clearly enormous frustration about the lack of data. I mean, it was very frustrating that this back and forth about the deaths data even, and that I felt I couldn't get reliable data from PHE, and the numbers kept like changing from hour to hour to the extent I got it shared. And that we didn't have like things like geographical, I mean, I didn't know those charts, but in general, like, we just didn't know what was happening where and which care homes. Just seemed to be a complete gap. And the other thing was the concern about care homes not having the workforce they needed and being abandoned. So that was another thing I wanted to have data on, is how are they coping?
Well, maybe we can bring some life to this by looking at a capacity tracker data. Can I have on screen, please, 327818? This is capacity tracker data for the 6th of April 2020 at 1840, and it might just need you to help talk us through it where it's not obvious. But look, if we look at the top box, care home daily update, the care homes that were registered with the tracker. Do I take it that not all care homes were necessarily registered with the tracker?
Sorry, and I failed to answer your last question, which was, yes, I spoke to Ros about what were our options, and the thing that was identified as the best option for providing data was an existing tool, I think, developed by sort of NHS in the North East, maybe, so that was being used already by some care homes to identify where they had vacancies of beds that people could be discharged into. Because that was already up and running, the decision was made to kind of build on that and extend it. But I think it took some time to therefore get all care homes filling it out.
But looking at this now as it was in April 2020, is this showing us a national picture?
I think so, yes.
Okay.
Yeah.
So there's 71% of beds are occupied, and then they can see how it's not occupied, registered. Bed occupancy, 90%. Vacant beds, there's 32,000 odd. In tracker registered homes, and then across all care homes, 45,000 odd. So potentially they're looking at that. There is capacity within the system. And if we could go out to the wider screen, we can see there a little bit of explanation. The tracker's being rolled out to all care home providers. 71% are completing the data on available beds, and a third now completing the red, amber, green rating also. And then there was other work in development. And care providers will be offered opportunity to flag if they have major concerns and need help instantly, and with the ability for the CQC to act or flag back to the local authority. And if we just look at the RAG ratings, to use that terminology, admission status, so just look east of England, for example, over 80% of care homes were open, a relatively small number were partially closed, and the red indicating that there were some care homes closed, clearly a bigger number closed in London, looking at that. Can we go to the next RAG rating? Overall status. Do you remember, Mrs. Whately, what this was trying to indicate to you? Because the next one is workforce status and the next one is PPE status, and we've looked at admission status, but I wasn't quite clear what overall status was.
I believe it's a combination of
overall
things brought together, but
Okay.
I
All right.
couldn't guarantee.
And if we go out and just look at workforce status, so the red is to indicate the number of homes that say they are really struggling with their workforce. And again, PPE. Red again, care homes where they're really struggling with their PPE supplies. Bigger numbers by the looks of things in London and the Northwest. So this was giving you, that was the position as at the 6th of April. Were you able to go to the sort of next layer down and know which local authorities were having the particular problems? And in due course, I think we were able to go down to which care homes were having the particular problems. Is that right?
We were over time,
Okay.
and that was part of the reason for building this out. And also, though, over time, building our capability to do something about it. Because one of the challenges in the early days is even when we could get the data, for instance, to a local authority level, actually the department had very limited capacity, people who could, whether it's contact local authorities or contact individual care homes, which was why we subsequently built that regional team, and in between we boosted the operational sort of skill set within the department to have people who would pick up the phone to find out what was going on. Because my view is, okay, data is helpful, but we need to be able to take action based on the data.
One of the things you do say in your statement is you recall asking early on in the pandemic for data as to deaths related to COVID-19 in the workforce, but that was not available. And it was only later you could get them via looking at the number of people that had applied for the compensation scheme. Do you know, as the pandemic progressed, whether there was any work done to get data about the deaths of the workforce from COVID-19?
I remember there being conversations about it because I wanted it, and I wanted to know, where members of the social care workforce had died in specific providers, was even to be able to, offer support and, in fact, contact people to let them know about the compensation scheme when we set that up. But I don't believe it was possible to do that. I think we had to rely on more sort of broadcast approach to communicating about that.
All right. Do you think that there should be data kept about the numbers of the workforce that die in the pandemic, particularly if they're the ones going out on the front line putting themselves at risk?
So, yes, I think there should be a much more substantial data set about the social care workforce. You've got around 1.5 million people looking after extremely vulnerable people. And at the moment, we have a system where, in general, we don't know who that workforce is. We have no way of contacting them. We don't know what their qualifications are. And there are all sorts of reasons why it would be much better to have a system where in healthcare, with registered nurses, there's a register of the nurses and what skills they have. You don't have that in social care. It is one of the reforms that was in progress when I left as social care minister, was to set up a digital register that people in the social care workforce could register their qualifications on and could become the foundation for having that kind of set of information.
As we understand it, there is still no register for the adult social care workforce. Certainly Mr Hancock and indeed a number of other witnesses have commended that as a potential recommendation to Her Ladyship. Do you have any view on the utility or otherwise that a register would have brought to the pandemic?
Yeah, I think it would have been extremely helpful. I mean, one of the uses, for instance, is it was raised with me the concern about whether social care staff had skills in infection prevention and control, whether it was PPE, but also wider IPC measures. And so we rolled out a training program through the NHS to disseminate those skill sets. But I had no way of knowing whether all of the workforce at a particular care home had or hadn't had that training, for instance. So it would have been good to have a register in which it's just noted somewhere, somehow, yes, so-and-so has completed the training, for instance. And on a broader scale, as I said a moment ago, you've got people looking after other people who may be vulnerable, have quite complex health conditions. Many care workers are very skilled, but at the moment, a family won't necessarily know the person looking after their relative, whether they do have a set of skills or not. So I can see a value outside the pandemic as well.
Do you have any views as to who should compile the register and maintain it? Is that a new body, a body that's already in existence? So
I initiated work when I was a minister to build the infrastructure to do this and to enable it on a so the sort of online version of the register would exist and to be initiated on a voluntary basis for care workers to register their formal skills and qualifications. So and if I recall right, that was working with Skills for Care on it. So there was a way of doing it envisaged that there are different ways you could do it, but achieve that outcome.
Do you think the department should play a bigger role in trying to force this through and indeed maybe even maintaining the register? Would it be feasible for the Department of Health and Social Care to act in that way?
I think I'd be open-minded as to whether something should be done in-house or outsourced. Government department isn't necessarily the right organisation to maintain something like this. If you look at the equivalents in healthcare, I know the Royal College of Nursing, it's NMC rather, that maintains NMC?
Yeah, Nursing Midwifery Council. Nursing
Midwifery Council, thank you, has a register for nurses and midwives. So it doesn't have to be in-house, but I think a respected organisation clearly to do it. And Wales already has a register for the social care workforce, so that's also a model to look at.
I think a number of the DAs do in social care as well. Just briefly about the dashboard, we know it was rolled out from the 1st of October. In fact, we looked at an example of it yesterday. And Ms Dyson we looked at national, and she said if you click through, you can essentially get down to care home level. But in its the run-up to it being rolled out, were you ever aware that you were being met with in private by people wanting to talk to you about the dashboard because there was some hesitance or reluctance for you to be given the dashboard data?
No, and I think I strayed into this this morning when I said I think there was a brief moment where I had some issues with a login because of a laptop, a technical thing. But no, in general, I had good access to the dashboard and I looked at it at least daily.
Were you being briefed without senior members of the DHSE Adult Social Care team knowing that you're being briefed about the dashboard?
I don't recall that in general, no.
Can I just ask about a few messages in October 2020 which build on questions about the dashboard? And can we have up on screen, please, INQ 2740628, thank you. And at 18:29, so 6:30 that evening. Can we see at the top there, you checked in about the dashboard. The local directors of adult social care get to see national top-line data and local data. I'm told the decision was made to give them the national picture as context. And Mr Hancock said, not by me it wasn't, and you said, indeed, it didn't come up to you or me. What was the problem, or was there a problem with local authority directors getting to see the national, indeed local data?
I'm trying to think through, because what I am remembering for this time is wanting to give local authorities access to more data, because I felt we had at the centre access to a lot of data, and I felt it would be very informative for local authorities to have it, although I think there might have been some nervousness about local authorities seeing other local authorities' data down to the specific care home level. So that was an area that had to be worked through. But I can't remember more specifically what this is referring to.
You go on to say, I can find out feasibility of removing access to the national info, although it would be a conspicuous change. And Mr Hancock says, well, what do you think we should publish? If we do publish care home cases, no harm in putting it on the local authority dashboard. And you said, I think we should publish weekly positive tests with staff and resident breakdown and deaths, COVID and total. There may well be a bad initial reaction to 5,000 positive cases in care homes, but I reckon we have to ride that out. As it's mostly staff, it makes the point that you have to keep community rates down. And it looks like you linked to some other data that's available, including a French one and I think various other European ones. You say, how quickly do you think we can get it published? I think ASAP, so if possible before local authorities leak it. He asks you to work it up. And then towards the bottom of the page, you say, I'm on the 28th, I'm chasing the adult social care team for a proposal to publish care home cases and deaths. Urgency driven by the fact that the dashboard rollout to local authorities is well underway.
Yeah, sorry. So what you've just run through has reminded me of something. So one of the issues here was about...
my fault, I didn't give you the whole 5 days.
Is about the tests. So, and I was indeed monitoring what France was publishing, because they were good on transparency, I felt, on this. And so I was wanting us to share and publish the level of positive tests that were sort of happening in care homes. And then there was a debate, do you do it down to the local authority level, do you do it down to the specific care home level? And then a concern that if you publish down to care home level, and then a member of the public could see that the care home there had got a very high number of positive tests, well, might that deter the care home from testing? So that's what's going on here, is a worry that if you're so transparent, would it mean that the care home would go, oh, we're going to stop testing our staff and residents because that's going to affect, be bad publicity for us. So we're trying to think of the unintended consequences of the level of transparency. So that's what's going on here.
That makes sense. All right. So in due course, though, did you ever get any sense that people were either not reporting COVID positive tests because they were worried about adverse publicity or a bad reaction, or was that just something you were concerned about but didn't actually materialise?
The latter. I was concerned about it, but I'm not aware of it actually materialising. And what I'm trying to remember now is, did we end up publishing it down to care home level, or it might have been that we published it not down to that level anyway, we ever ultimately published more to local authority level.
Local authority level. All right. Thank you. Can I ask you about data in respect of black and minority ethnic social care staff? Because I have to confess we're struggling to find good data on this. Do you have any observations on whether there was a good level of detail about the numbers of black and minority ethnic social care workforce, and indeed of them, those that became infected?
So we knew, and I knew a fair amount at a high level about the composition of the adult social care workforce at the outset of the pandemic, including significant proportion of members of the workforce from black and ethnic minority ethnicities. So we knew about that, and we knew about the majority of the workforce being women. We knew about broadly age of the workforce. I think probably from Skills for Care data would be a good data set on that. So we knew those things, but we didn't know the deaths data in that way for the reasons I mentioned a moment ago, is that we just had very poor information about care worker deaths.
Yeah. And And given the disproportionate impact that we know that COVID did have on members of the black and minority ethnic communities, clearly, presumably you would advocate for more data on the ethnic minority workforce. Can I just ask you about this, though? We've seen that you had a number of meetings with the NHS Chief People Officer.
Yes.
In at various stages, and I just want to be clear that it didn't mention adult social care in those meetings. Is that deliberate because that wasn't the remit of those meetings, or was it an oversight that the adult social care sector wasn't mentioned in those meetings?
So I would have met Prerna Issar as the NHS Chief People Officer in my role as Minister for the NHS workforce. So we worked together significantly during the pandemic on support for the NHS workforce, for instance, on the mental health side, amongst others. And one of the things I worked with her on was the concern about the risk to black and ethnic minority workers in the NHS and the rolling out of the risk assurance framework.
There's a risk reduction. There was a health risk reduction
for
framework.
health. So that started first in the NHS and across the health workforce. I mean, in part because of just there is the structure in place to do stuff for the NHS and health workforce. Greater pay, basically more people working essentially on that. And then I took the decision for us to piggyback on that and roll out something similar for the social care workforce, saying, well, we can do that for the NHS, let's do that for social care. Whether I formally talked to Prerna about that, I can't recall, but she certainly would have been somebody who'd be helpful about thinking more broadly about the social care workforce.
You mentioned the social care risk reduction framework, which was published on the 19th of June 2020, and there are certainly concerns from a number of the core participants that this may have been too late. Do you know why it wasn't published before mid-June?
So the sequencing, I remember, is the awareness of which staff were and people who would be at greater risk. Then the NHS taking the lead on this because they, not least because they had people to work on that sort of thing. And then, as I say, us developing it, adapting it for social care, and then rolling out for social care as quickly as we could. So the timing is a consequence of that sequencing.
I think in the sequencing, it may have come out after the NHS one, as you just alluded to. I don't want to be unfair, but is that another example of potentially being social care lagging behind decisions that are made for the healthcare sector? Is there a particular reason for that?
I mean, it's factually lagging, and self-evidently. That's a consequence, I think, of the resources that the different sides of the system has. So the NHS had a chief people officer then. Social care didn't have a national HR function in the same way. So it's a resource reality.
And may I briefly touch on the topic of testing? And I know you've given some evidence about testing before, but just can I go to your paragraph 183, please, Mrs. Whately? And on the 7th of April, so this is just before the action plan comes out, you received a submission on the prioritisation of tests. And the submission proposed that during April, while capacity was being scaled up, tests should be prioritised for frontline NHS staff. And if we look at the top of the page in your statement there, this actually, can we go back out, please? Thank you. There you are. The paragraph that begins 15 actually repeats what's in your submission, all right? And it says there, in the short term, while capacity remains limited, our overwhelming focus will therefore be tackling delivery issues for NHS key workers, ensuring we maximise the use of available capacity to test NHS staff. Where we have spare capacity, we will look to fill it with other very high priority key worker groups who can easily dock into the existing infrastructure. And essentially what it meant was that frontline was the NHS across all settings, and social care workers to get testing where capacity allows. Now, I think you had some concerns about that priority, and if we look at an email that you sent on the 8th of April at INQ 327822, And if we just look at your top email there, apologies for the delay. The Minister's reviewed the submission, is fine with the overall text. However, she's concerned, it appears, we will prioritise NHS staff over social care staff rather than prioritising based on the risk to care of staff absences. Why were you making that observation that we are prioritising NHS staff over social care staff? What was your worry?
Why was I worried about social care staff being lower priority?
Yes.
Well, the biggest worry at that time was very large number of staff absences, and therefore neglect and loss of life due to neglect in care homes. And the testing that was used, and one reason why the NHS was testing so much, if I recall, was in order to identify if people didn't have COVID, if they had sort of a cold or something else, that they could still go into work. Well, the same applied in social care. If you were worried that people were not going into work because of some other symptoms, when actually it wasn't COVID, well, and I was really worried about social care staffing. So I thought the prioritisation should be where you had the greatest sort of vulnerability of services to staff absence rather than a NHS then social care prioritisation.
Yeah, although I think, in fact, your argument didn't win out, if I can put it like that. And there was the priority given to NHS staff until later that month in April there was sufficient capacity to test all. All right, can I ask you about asymptomatic testing of domiciliary care? In your statement, you say it was introduced on the 23rd of November 2020, but the inquiry's heard evidence from Jane Townsend that although it was introduced in November 2020, it wasn't available in practice until January 2021. Were you aware there was a time lag, for want of a better phrase, between it being introduced but actually in practice home care workers being able to access asymptomatic tests?
I would have to look up
Right.
what I knew about that between November and January.
Right.
I can do so and let you know subsequently.
Thank you very much. All right. Can we come on to visiting restrictions? And the arguments for and against, I suppose, to put it like that, are well known to her ladyship. And you indeed touched on them this morning, Mrs. Whately, when I asked you about some of the things that went well and didn't go so well. One of the things you do say in your statement was at paragraph 278 is that you obviously were worried about the visiting restrictions leading to social isolation and the effect of mental health on residents, and you commissioned research into this area. Are you able to tell us the outcome of that research and when it was commissioned and what it informed you?
So yeah, I commissioned it and actually what happened was a review of existing research rather than kind of fresh research, I believe. And it looked particularly at examples from the Netherlands and I think the US, where there was evidence of visiting restrictions being to the detriment of the well-being of care home residents. Well, that was the upshot of the research.
Did it help inform how the visiting restrictions policy or the visiting guidance developed thereafter? I mean, there was always the tension between trying to protect the residents from the infection, but equally acknowledging the deep harm it had done to them and indeed their loved ones who couldn't see them. But did it make any material difference to how the visiting guidance developed?
Yeah, I mean, it contributed to the argument because up to that point, all the data had been about the risk of COVID and deaths from COVID and the direct sort of COVID impact, the disease impact. And then there was no data on the other side. And therefore, on that basis, sort of no visiting at all would be where you might go. So I was looking for an evidence base to balance against that weight of evidence, which is, but hold on, there is actually a harm of stopping visiting to care homes, and so that was, it contributed to the conversation about that, albeit that that there are various points, and particularly during the winter, during the sort of second wave of the pandemic, when there were greater restrictions on visiting, and I came under a huge amount of pressure, including from the Prime Minister, who felt very strongly about stopping visiting.
I was going to ask you about that, actually. And I didn't mean to interrupt you, but if it makes sense to deal with that now, can we have up on screen, please, INQ 2740268? This is in October 2020, where you wrote a series of WhatsApp messages to Mr. Hancock on the subject of visiting, and it's underscore page 27, sorry. And the message is at 18:23. Top message, thank you very much. You were due to speak to someone called Wade next week. But overall, we really need to enable COVID-secure visiting. I think our restrictions now mean too many care homes allowing too little no visiting. presumably Nadine Dorries, had a meeting with the Prime Minister last night, and a family who recently lost both parents in a care home without being able to see the dad. She's told me the PM wants us to follow the approach in the Netherlands, which is much more visitor-friendly. And you say, I've asked the private office to check if that really is the PM's position. Check with you, check with Jenny Harries. Meanwhile, I don't think we should publish the new, more restrictive visiting guidance, which was basically driven by Number 10, ban visiting steer, and DCMO has been consistently against. And Matt Hancock says effectively that he agrees with you. So can you just help unpick that? Because it sounds like there's two messages coming through here. There is the Number 10, there should be more restrictions, but then if one reads the message that references Nadine Dorries, potentially an approach which is more visitor-friendly. What can you help unpack that for us, Mrs. Whately?
Yes, so Number 10 was, up until that point, very strong on let's ban visiting. At some point earlier on in the winter, when we see the numbers going up, and the Prime Minister sends a message, I think it's somewhere in the records, of sort of stop visiting. And I have an argument with him about why there is a case to continue to have some visiting in a controlled way, because I was very aware of, I think, the harm of stopping visiting was doing, and also because there are circumstances and ways in which you could do visiting in a way that very much reduced a risk of a visitor bringing in infection, and the evidence has showed us the infection was much more driven by to do with staff unwittingly bringing the infection in. But the Number 10 position, I think it reflected, having seen the awful deaths in care homes during the first wave, Number 10 was understandably very, very cautious, let's do everything. While I had this, I guess, a more nuanced position, having spoken more and heard more from families, particularly, as well as staff. However, Nadine Dorries had been to see the Prime Minister and involved a family who brought a very personal story to the Prime Minister, and actually that, I think, shifted his view on it. So I then hear in this message that his view has shifted and he's more open to allowing some continued visiting. But then in my message of, therefore, sort of 1825, I'm saying, well, can we really check? Because I wanted to know what the official Prime Minister's position was rather than just hearing it sort of word of mouth.
I think in due course, that in that winter of 2020, there was a huge spike in infections. And I think the Prime Minister wanted to stop visiting again by that winter of 2020. Can I just ask you there, you spoke there obviously about the desire to prevent the infections coming in, and then what you've learned from your discussions with the families and the loved ones. But the inquiry, I think, disclosed to you a witness statement from an English care home dealing with the care home's perspective on the visiting restrictions. And can I, through you, just ask you about INQ 587678_4? I'll just take a moment to come up on screen. And this care home made the decision to preemptively lock down. You can see there at paragraph 5.3, it must be said the ban on visitors impacted significantly more on family members as it did on the residents, because in fact this was a care residential care home for adults of all ages with a learning disability and a lack of capacity. So they didn't understand the significance of what was going on. But if we go down to paragraph 5.4, they say that the care home, the only way they could facilitate contact and family members was by Skype and phone. The family members found this too distressing, and the process of scheduling the calls and the video calls was extremely onerous on a weekly basis for the 65 residents. And indeed, if you go on again to paragraph 5.5, there was then window visits in the autumn around November. The risk assessment was prepared, and they were allowed to use a closed area in reception. It was approved, and it said they provided the same, if not greater, challenges to staff as it was different to schedule, and due to the number of residents we had, it took staff away from routine care tasks. The manner of visiting continued for many months into 2021. And indeed, can we just briefly go on to 5.7 and 5.8? The care home says they spent a substantial amount of money on adapting a specific room that was a way for residents to allow and had access for visitors. That was approved. And as we'd moved on in time, and there's clearly testing now available, the process was that visitors would attend 30 minutes prior to their scheduled visit. They'd be met by staff in a designated testing area and provide a lateral flow test. So again, clearly taking staff away to be able to facilitate the tests. And can you tell me, were you aware of the impact that the changes to the guidance were practically having on the ground for care homes were doing their best to try and facilitate visiting? And if you were aware, what were you trying to do to help ameliorate this position for the care homes?
So yes, I was aware. I was hearing from care homes about how difficult they were finding. I was hearing from care homes who were finding it very distressing that their residents weren't receiving normal visits and that staff were having to work very hard to maintain the morale of residents who were really upset that they, and confused that they weren't getting the normal visits. So that was one of the things I heard from care homes. And then I also heard the difficulty of complying with was testing requirements or meeting window visits or other things. And I know care homes made a significant investment in facilities to try and enable some of that sort of COVID-safe visiting. One of the things we did is that one of the allowed uses of some of the tranches of the Infection Control Fund was to fund extra staffing costs or extra facilities for visiting. So that was one of the allowed uses of both that and the testing fund, I think. So these were significant amounts of money that were distributed to care homes to help them with the extra costs of visiting.
One of the other aspects of the visiting restrictions I'd just like to ask you about is potentially restrictions on healthcare professionals entering care homes to provide care. Now, I think, is this the position? There was no blanket ban on GPs or other healthcare professionals attending care homes where it was necessary for them to provide a visit. Is that correct?
Correct. I don't believe there was a blanket ban. And it was something that I looked into because I heard quite a range of stories on this. I heard from care homes who were distraught that they felt they couldn't get any attention from healthcare professionals. They couldn't get a GP to come in. They weren't getting district nurse coming in. And staff were really struggling with sick residents and without getting healthcare help. And then I heard from another care home whose GP, they said, was absolutely brilliant and was giving a huge amount of support to the care home. Whether it was, and I can't recall with that particular example, whether that was in person or through fantastic video calls, but either of those could actually work. You can do quite a lot by a GP who was very readily available doing video calls. So there was this great difference in the level of support that social care got from the NHS. And that was one reason why there was a very specific intervention I did involving Simon Stevens, I think involving the Prime Minister, to get NHS England to commit to expediting enhanced healthcare and care homes, and this model of a very focused attention from GPs and every care home to have a named clinical lead that they could call on, and the NHS committed to delivering that.
Well, what you just said there, echoes a number of contributors to Every Story Matters records, and I just want to put up two very brief examples. I have on screen 587565_153, but on the positive side of the coin, we can see there that one care home worker from England said the GP was there to give advice and guidance from the beginning. We didn't see them really in person, but they were on the phone, and they really supported us through it, to be honest. A positive account there. But if we go to page 1_154, staff working in care homes told us that in-person GP visits were very infrequent. And look there, just two quotes. Our GP, I did a lot of video calls with them. It was hard to get them to come out. And the next quote, as soon as the COVID hit and we went into lockdown, we really struggled to get any doctors, or it's mostly the doctors that would not come into the care home. They quickly started giving instructions over the phone and giving us more and more responsibilities in terms of how we needed to manage the residents. Do you know whether the enhanced health in care homes programme did in fact ensure that the care homes had access to a GP? I think it was a named GP.
I mean, it was intended to, and Simon Stevens and NHS England committed to delivering it. I think in practice, and I've seen some reports saying no, that didn't make a difference with some care homes. So I suspect that there was variability in how it was implemented. I think there's also a bigger question here: is like, what happened here? Like, why? And I find myself asking, why, if you're a GP that you know that you've got a care home that's within your catchment area and you usually look after the residents in that care home and you know that they're having a really hard time because of COVID, why aren't you there for them? Why aren't you making sure that either you go in person, or even if you feel you can't do that, maybe you're GP who has some vulnerability, you're worried, albeit clearly care home staff were going in, why aren't you in touch with them? As I say, I know that there was some great practice, but why was that not the rule? Is a important question to ask and try and get an answer to.
Can I ask you about DNA CPRs, please, Mrs. Whately? And
yes.
Not going to go over the CQC interim or indeed final reports. We're familiar with that. But in your paragraph 384, you say on the 25th of April, your private office sent an email to ask individuals in the department to investigate an article that you'd read, which reported an unprecedented, quote, number of DNAR orders that were being sought for people with learning disabilities. And you asked for contact to be made with Turning Point within the next 24 hours to find out what was happening. Can you just help us about what you learnt when you, I think, spoke with Turning Point a little while later on, and indeed, I think maybe had a meeting with them?
Yeah, so they had evidence that there had been a substantial rise in the number of DNA CPR decisions made. And I think they said, and it's paragraph 386 of my evidence, that they'd seen about 13 decisions made in the last 3 years for the people they support. But in contrast, they'd seen 13 in the last week when no best interest test had been undertaken. So we're clearly going in a dramatic increase in numbers from 13 across 3 years to 13 in 1 week. So evidence that was happening. I think also it's another one where your Every Story Matters document is helpful. And one of the bereaved family members there, I see, says that the priority of the GP for care homes was to move all residents onto DNA CPRs in one example. So there clearly were examples that come clear retrospectively and some evidence at the time of this significant increase in DNA CPRs.
Yeah. Did you ever, in your role as Minister, come to learn about why there had been such an increase? Because we know that it wasn't any guidance that went out, and we know it certainly wasn't approved by the BMA and the RCGP and all the other organisations that firmly deprecated this and indeed had done for many years. But did you or the department ever really understand why there had been such an increase, particularly in March and April, of DNA CPR orders being imposed?
I didn't receive evidence that would tell me why. I can hypothesise, but I've got nothing which is like, this is the explanation for why that happened.
Finally, I know we've covered a number of topics with you, Mrs. Whately, and indeed in your addendum, you provide a lengthy statement setting out your observations, reflections and lessons learned. I'm not going to ask you to repeat that. But is there any other reflection that you would like to give, or any lessons learned that you think would genuinely help address some of the problems that we've identified in the response to the adult social care sector?
Yes, and thank you for asking me. I think so, and I'll just run through a few of that's all right. So firstly, there is a job to do to understand properly, so clinically, what happened with this pandemic in social care. And I say this because recognising that other pandemics may well be different, but alternatively they might be similar. As I said earlier, I think we still don't understand whether the right PPE was being used for social care or not. And fundamentally, how come when we had the PPE, we had the testing, we had designated settings, we had put in place short of completely banning staff movement, but restricting it. A lot of things that should have protected care homes from COVID outbreaks in the second wave. But still, there were a huge number of outbreaks. And it still feels to me like that work hasn't been done to really get to the bottom of it. Now, there are care homes that had either no outbreak or very few outbreaks through the whole of the pandemic. What were they doing that was so different from the ones that did have multiple outbreaks? And obviously size was a factor, but you could look at care homes of a similar size. I think there is still work to be done to get to the bottom of what protected some versus others.
Who do you think, or how do you think that work should be done?
We have. Was it the UKHRA, Health Research?
The research, NIHR, I think it is, but...
Yes, okay. Yes, I'm combining. We've got UX on the one hand and the NIHR, which can do health research. So that their remit includes social care, so that would be one avenue. I think there's a role for UX, UKHSA in this as well. And there's something about building up greater research capacity in social care, like we have for healthcare. I mean, for instance, I did actually look at the UXA strategic plan recently. That mentions the NHS 52 times, but social care is only mentioned 4 times, and it's only mentioned in the context of the Department of Health and Social Care. So why is that organisation not seeing social care as something that, given what's happened in the pandemic, why is social care not a feature in their strategic plan? So there's getting to the bottom of what happened and building up that research capability and oversight of infectious disease management in social care. There's going back to sort of kind of where we started today is proper pandemic planning. And clearly, when the pandemic starts, it's too late to make a plan when your pandemic has already started. And in fact, we know looking through the data that deaths were occurring in care homes almost certainly from COVID from mid-March onwards. So it was there, but the planning was it came subsequent to that really. So you do need a proper plan that goes through all the things like PPE and the discharges process and what you'll do about funding and visiting, vaccination policy, and the various scenarios. So that needs to take place. There's this point about having some great level of capability and infrastructure at the centre to be able to do a coordinated response. It took time to build that up. We went from having, I think, less than 100 people in the social care part of the Department of Health and Social Care to over 300. Now, we've built it up, but there was a time that took to do that. And similarly, local authorities needing to have the capability to do that, and care homes themselves having the capability to respond to a pandemic, and all those levels need to be in place. On the staffing side, and we have talked about that a bit, the need for recognising staff, professionalising, recognising the status and skills of staff, making sure staff do have a formal set of skills, and giving as much attention to the supply of social care staff as we do for other staff across health and social care. I think that is very, very important, and I'm not confident that it's happening. There's the status and representation of social care in government, and also the relationship between the NHS and social care sectors. So we've talked quite a lot about what happened with the discharge process and how that happened, and the NHS sort of saying social care needs or requires or will take people. And say, I understand the NHS lens on that. But why didn't NHS leaders say or think about the impact of that on people living in care homes and the health of those people? It was almost as if what matters was hospitals and not the health of the whole population, including those living in social care. What would it take for at the time, the chief executive of NHS England, NHS England's been disbanded, but the leadership of the NHS to be thinking about the health of the whole population, including those who receive social care? And I think that is worthy of thinking work on. And then I'll say, I guess, so one more thing just to reflect on is, as part of pandemic planning or being ready, is thinking about how you prepare and support the leaders of your system. That's both sort of civil servants, other people in positions of responsibility, indeed ministers themselves, to be able to respond and do a good job in an extremely unusual situation. Because providing leadership through a pandemic is very different from almost anything else you're ever going to experience. And I know I thought about it at the time as like, what do I need to do to make sure that I am making good judgments, that I'm getting the right balance between absorbing huge amounts of information and keeping my head clear to make the right calls, or to ask the right questions, or to make sure stuff is happening. Sometimes you've asked me questions about, well, that was a policy, did it actually happen? Like, how are you making the judgments about how you spend your time? So all of that, I think it would be worth in a peacetime outside a pandemic, as to thinking, how would you make sure that those people who are doing leadership roles at a time like that are best supported to do the best possible job in what's going to be, in almost any circumstances, however well prepared you are for it, to do it as well as it could be done.
Mrs. Whately, no doubt great food for her ladyship's thought. Some of it may be a little beyond the terms of reference of this inquiry, but nonetheless, they are all the questions I have for you. Thank you very much. And my lady, would that be a convenient moment for the afternoon break?
It would indeed. I shall return at 4:25. Last furlong, Mrs. Whately.
Thank you, my lady.
Miss Morris, can you hear me?
We
Thank
can,
you.
my lady. Good afternoon, Mrs. Whately. I ask questions on behalf of the COVID Bereaved Families for Justice UK, and I've got 4 topics to ask you to expand and clarify on, please. The first topic is hospital discharge policy, and in particular, I want to ask you about your views about the success of that policy. Because at a healthcare ministerial implementation group on the 7th of April, the minutes record that you said that, quote, discharges from hospital into the community to increase NHS capacity had been hugely successful. And you observed that non-COVID bed occupancy had reduced by nearly 40,000 patients since the 2nd of March against the target of 30,000. So my question is, was the success of the policy only measured by unoccupied NHS beds? And I ask you that because, based on what you said in evidence this afternoon, I anticipate you'd agree with the perspective of the bereaved that I represent. This is about lives and not about bed numbers.
Yes, and I think the minutes to which you're referring is probably where I'm there as a ministerial representative for across the Department of Health and Social Care, and therefore sort of giving a broad update on a perspective, and from the NHS side of the department, the policy was they would have seen it as a success because they managed to discharge lots of people and free up lots of hospital beds. Clearly, for me, looking at it as a former social care minister, I have a different perspective on it, which is that I have a concern that it was one of the sources of infection into care homes at that stage. In any event, also put care homes in a very difficult position where they felt they were sort of required and made to take people, admit people discharged from hospital, that they were very worried about doing so. So that gives it a less good verdict, shall we say, as a policy. I still think that there is a gap in the work that could and should be done to look into the impact of that policy, where it's well known that there are various reports done about what was the main cause of infection going into care homes, and those reports tend to look at the period for which we had significant test results and identify that the vast majority of outbreaks were seeded from to the wider community rather than due to hospital discharges. But I think it is unknown about the early period of the pandemic and to what extent infections went into care homes during that early period from community, for instance, staff or visitors versus the discharges. And the rates of excess deaths started to increase in care homes in sort of mid-March-ish, sort of maybe around the 18th, 20th of March, that sort of time, implying that you were beginning to see COVID deaths at that time, even though there wasn't the testing to prove that. And I think there could still be, I would envisage, a piece of work done to say to what extent were those increased, where those deaths occurred, were those in care homes which had taken discharges from hospital versus not. I believe that could be investigated, but I haven't seen that done.
Thank you. My second topic is around testing for domiciliary care workers. In a submission on testing in care homes dated the 9th of May 2020, you're recorded as saying that the UK government should, quote, in parallel, be piloting the blanket testing of domiciliary care workers in order to understand whether there are widespread asymptomatic carriers among them. And on the 19th of May, you say that you agreed that PHE should conduct a quick study of blanket testing with one or two domiciliary care providers to identify whether there were, in fact, domiciliary care workers with asymptomatic COVID and associated COVID amongst the people they were caring for. And the inquiry is seen on 26th of June. You sent a WhatsApp to Matt Hancock referring to an earlier meeting which said, very helpful meeting, thank you, glad I badgered PHE many times to do a dom care testing pilot. So I wanted to ask you, was your recommendation of the 9th of May 2020 taken up, and if not, why not?
So from what you've just outlined, there was a smaller scale study. What I don't have in front of me is what the results were of that study, which would then have informed the subsequent policy, I believe, but I don't have those results with me.
All right. Why did you have to badger PHE to do the pilot?
I'm trying to think back to what the conversations were at the time, and I can't tell. I mean, evidently from me saying that, I was obviously having to push for the work to be done. What the reasons were, again, I could hypothesise whether it was they were busy doing other things, concern about testing volumes, but I'm not sure. I'm sorry.
I was trying to get at whether it's an example of kind of your, and in this case, important steer being ignored by those who have the power to put things into place.
I mean, in general, to your question about domiciliary care, and I think the record will show it, is that at multiple occasions, I'm making sure that we're thinking about care homes, both for older people and people of working age, in fact, and domiciliary care services. And there were situations in which people tended to focus on the care home situation because that was where the headlines were. But I was always also thinking about, well, what about domiciliary care? I know that from the point of view of lots of clinical advice I got, that there was greater concerns about COVID in care homes because of the nature of the environment in care homes, where it was so difficult to control the spread of infection around all the residents in any facility, whereas dom care was more likely to be one person receiving care into a different form of setting.
Can you help with whether a quick study was completed later on in May, and if so, what its findings were?
So that's where, if PHE agreed to conduct it, and my WhatsApp exchange indicates that it happened, but I don't recall what the findings are.
Okay, all right, thank you. My third topic, the inquiry has seen emails around 21st of April 2020, which it seems that you were asking for advice on the introduction of what you've referred to as a carer's wage. I wanted to ask you whether you'd received advice on that and what that advice was.
I believe I received advice. There certainly have been many conversations about that and whether you could raise sort of specifically higher minimum wage for care workers.
Was that what you were sort of identifying?
That was one of the things I looked at, and in fact from that email exchange you can see that it's clearly something that had been looked at before. I was not the first minister to ask it. In fact, where I subsequently, as a care minister, took the view that what needed to happen to improve the supply of care workers was particularly career progression, and that while somebody might start off at a lower end of a pay scale, the particular problem, I believe, with social care is that it's very hard to progress up a scale, and that there's plenty of evidence around Skills for Care, amongst others, that even if you've worked in social care for like 20 years and got a huge amount of experience and expertise, you will get little or no extra pay to reflect your extra expertise. So I want to see a situation where people can actually build their expertise and be recognised for the extra responsibility and work that they're doing, hence the work I did to try and build a career path for people in social care.
But why wasn't it ultimately introduced? Can you help?
Why hasn't a care worker's wage been introduced? I think it's looking at there's realistically the funding challenge that to achieve a material uplift in pay for over 1.5 million people working in social care, you're looking at a lot of cost. Is that the right way to do it versus, as I said, actually having better pay progression? We now have a new government. We will see what they'll do. They're talking about doing it as a carer's wage, but I haven't seen them commit any funding whatsoever to it. So.
Thank you. My final topic is returning back to looking at DNA CPRs, please. And at paragraph 380 of your statement, you say that you recall being told about the inappropriate use of DNA CPRs, but can't be certain how you first learned of that concern. But the inquiry's already seen an email from Professor Vic Rayner of the 3rd of April 2020, directly emailed to you to escalate the amongst other things, the PPE concerns that one provider has, and to alert you to the practice of one CCG who is reportedly issuing blanket DNA CPRs to care home residents. It contained a reference to a CCG in Birmingham and Solihull. So I wanted to ask you, on receipt of that email, what immediate action did you take to investigate whether there was, in fact, such a practice at this CCG?
So I don't know the specific email you're referring to. When you say directly to me, unless it was to my personal email address, it won't have been one that I directly opened and looked. And when I say I have a private email address my family contacted me on.
Understood, yeah.
But an MP or ministerial email address will not come directly to me.
It's to your office, to your private secretary.
So for my office, so therefore I won't have necessarily sort of seen that or read that, and I don't recall being told that there was a specific CCG where this was happening. As I said in my witness statement, what I recall is learning that there were issues with DNA CPRs being put on people inappropriately and investigating them, and then there was a whole set of communications that went out to say that this practice was unacceptable. I also subsequently triggered a review of patient records, I think, to try and go through and identify where people had had a DNA CPR put on them that they hadn't consented to, and to try and undo that. And that was a concern later on as well.
Thank you. Those are my questions. Thank you very much, Mrs. Whately. Thank you, my lady.
Thank you, Ms Morris. Ms Weston. Ms Weston should be across the hearing room down to your right, I think.
Thank you, my lady.
Oh, sorry. It's hard giving directions when you're miles away.
Certainly is.
Sorry, Ms Weston. I knew where you were.
Good to know. Thank you. Good afternoon, Mrs. Whately. I'm asking questions on behalf of the Frontline Migrant Health Workers Group, representing the interests of migrant social care workers. My question concerns the Infection Control Fund. You've already made reference today to the concerns expressed to you by Unison that ICF wasn't making its way to the care workers themselves. And in June 2020, you wrote to Unison stating that local councils would allocate ICF on the condition that they were used as stipulated, and that councils would use reasonable means of recouping wrongly allocated funds. However, a survey of Unison members in July 2020 found that more than half of care workers, 52% in fact, said their employer, the care provider, was still paying less than £100 a week, or nothing at all, if they needed to shield or self-isolate. And my question is this: do you agree now that the enforcement of the use of funds under the ICF was wholly inadequate?
So you refer to the system we set up to try and get the money directly to care providers. In fact, the Infection Control Fund was introduced in part because the original, I think it was around 6 billion funding given to local authorities, which was intended to support, amongst other things, social care. I got response back from the care sector that they really weren't seeing material amount of that. So I was like, okay, let's do something directly. Created the Infection Control Fund, which is a very novel approach, but we had no way existing to pay providers directly, so I had to go through local authorities and rely on local authorities and doing a level of due diligence to make sure that it was spent as it should be, and also for local authorities to do the due diligence that staff were receiving pay that they should be. I mean, clearly what's evident from that survey, from other stories, that there's a very mixed picture, and some care homes did pay staff full pay for isolating, and others didn't. To me, that's one of the lessons, and to be better prepared for a future pandemic, is you need a system to make sure that when you have a policy like sick pay from day one, well, that is actually implemented. We didn't have the systems in place to be able to go down to individual care provider level to make sure that was happening. I mean, and the other thing that relates to it is I, many times as a care minister, subsequent to the pandemic, was trying to push for better terms and conditions for care providers, addressing the stories of care, for care workers, addressing the stories of not being paid for travel time, for instance, and unfair contracts.
Yes, I understand all that, but are you able to point to any material that shows that local authorities were identifying where funds were not being used for the intended purpose and recouping them? What were you doing to monitor that?
So I got reporting back about the fact that local authorities were scrutinising, and I got a data set that said, that even broke down, this percentage has been spent on stopping staff movement, and this percentage has been spent on visiting or testing. I can't remember, but I had a breakdown of the percentage of funds that were being spent. So clearly local authorities were reporting up the way the money was being spent. And in fact, I got complaints that my process was too bureaucratic and that I was demanded too much reporting. In fact, one of the pushbacks from the whole system was we needed to distribute funds without such an onerous requirement on reporting. Now, I'm quite robust on this. I say if I'm distributing large quantities of taxpayers' money for a certain purpose, I think it's perfectly reasonable to demand reports about it. But local authorities and care providers themselves said we were asking for far too much reporting. So I stand by it. I mean, as you're indicating, if anything, we should have required more specific reporting
Well,
are you doing this and that for your staff down to the individual care home level?
Indeed, and you expressed frustration that although there was the evidence was clear that the risk of staff movement was absolutely essential to be recognised, and you say that the money's been going out there, so why is it still going on? But would you agree that it's clear that one reason was because the ICF money wasn't being used to compensate workers for self-isolating?
No, so I think your hypothesis is perfectly reasonable. There's a point at which the money isn't doing what it could do to exactly make sure that people have sick pay when they're isolating, or the costs are covered if they stop doing hours in one setting in order to only work in another setting. If those things aren't being done, well, you're less likely to manage to stop your staff movement. So I think that we, in retrospect, could we have pushed for more specific reporting and say, I did my best to listen to the sector. One of the complaints I got from the sector was, and I don't want to be negative, care providers did an amazing job during the pandemic, and I know many organisations went the extra mile, but there was a view that we didn't listen enough at the early stages. We worked really hard with the Adult Social Care Task Force to set up lots of engagement. One of the things I heard was there's too much reporting, too much bureaucracy, but the argument you're making is actually you need that, and if anything, need more reporting to know that money's being spent the way you want it to be, and that there is compliance with those kind of requirements.
That's fair. Those are my questions, my lady.
Thank you, Ms Weston. Straight ahead for Ms Peacock, Ms Waitley.
Thank you, my lady. Good afternoon. I ask questions on behalf of the Trades Union Congress. My first topic is also around the Infection Control Fund. And this has been touched on already, but in relation to the proposed regulations to restrict movement of staff between care homes and the related need to reimburse care workers, you describe in your statement at paragraph 167, on 18th of December 2020, HM Treasury rejected the proposals to compensate staff through the furlough scheme, but said that they would consider extending the Infection Control Fund. You go on to say, I responded the next day saying that I did not want to go ahead without furlough payments being made. And indeed, you had received an advice on that decision which referred to the difficulty of proceeding with regulations to restrict movement of staff without a robust compensation mechanism, and that's at INQ 328026 at page 4. Why did you refuse to go ahead with the regulations without furlough payments being made? And you've already touched on some of the limitations of the Infection Control Fund, but why was the ICF not sufficient in that case?
I'm having to join the dots on what was going on here to recollect what was going on. I mean, so as best as I can reconstruct in my head, so I'm wanting to regulate on staff movement because I'm frustrated it's still going on, but take the view that there needs to be proper compensation for staff. I'm therefore in a form of negotiation with the Treasury to try and secure that. The Treasury is pushing back on my proposal. So, that is a negotiation in progress. What I recollect then is various things happen. One is which there then becomes much greater staff shortages. So actually we then got to a point where I'm then told that basically the unsafe staffing exception is going to end up being used so much if we implement it then that it's not going to have any impact. And then I think we move on to the vaccination programme. So I think it was that those events then happened probably while there was the negotiation was in progress to try and address the pay question.
And in your statement, of course, you quite closely link that decision not to go ahead unless it's with furlough payments. And just perhaps to help with your recollection, you received that advice which I referred to on the 18th of December 2020. And at paragraph 4, that the issue of the Infection Control Fund is described. It says, we've considered whether we can make the ICF do this job adequately. But even if money was added to make it sufficient, it's an unsuitable mechanism. Unlike the furlough, we cannot know whether providers pass funds on to employees. To date, we've not found evidence of providers having used the ICF to compensate lost hours. Is that an accurate summary of the reason you didn't want to proceed with the regulations with the ICF and without furlough?
Well, I'm confident that, as you described, it was a factor in the reason why I was having this negotiation with the Treasury to try and get them to do something which was more targeted, like a furlough scheme. As I've said, I think the main reason for ultimately not proceeding, though, was particularly to do with the problems of lack of supply of staff because the economy was reopening and we had higher COVID rates, and therefore that the unsafe staffing exemption would make the legislation ineffective. That was what then really got in the way.
Thank you. Turning to awareness of this issue with the ICF within government, minutes of a COVID-0 meeting on the 22nd of December 2020, at which Michael Gove and Matt Hancock were present, record that you explained that the challenge with the ICF was that there was no way of knowing whether the money had reached individuals. And the minutes of points made in discussion, although they don't ascribe them to an individual, record that on staff movement, the ICF was designed to support this policy, but its weak processes meant that funding was not reaching those who needed it most. The furlough was a well-tested mechanism for ensuring that funding reached underrepresented groups and was fair. Is it right then that the weak processes of the ICF were known within the department, and indeed more widely within government, in part as a result of you raising it?
I mean, it's likely. I think that that reflects what we've just read out. Reflects what I've been saying here in the conversation in general, which is that we knew that we could gather evidence through local authorities of broadly the buckets in which the money was being spent, but you couldn't trace it down to individual staff members getting pay to compensate them for lost hours, for instance. So it couldn't do that, and we had no way of getting it to do that.
And then turning to some of the reasons behind these challenges and the efficacy of the ICF in respect to providing full sick pay to care workers, which we've already discussed some of the challenges in quite a bit of detail, and the data by Unison has been mentioned, and you've referred to a mixed picture. By way of example, in August 2020, surveys suggested that at that stage, so 3 months after the ICF was introduced, only 25% of employers were paying staff who needed to self-isolate their full wages. And that data is at INQ 119075 at page 3. And then the suggestion recorded by Unison at that time was that care workers were not being paid by providers because not doing so placed more pressure on workers who tested positive to continue to work. Then in October 2020, minutes from a DHSC testing meeting, which I think was a tripartite meeting, Unison attended it, state that some homes have refused to sign up to the ICF because they're worried it will mean they'll have to accept the principle of paying staff in full for all future forms of sickness. So a concern about setting a precedent expressed there. To what extent were these challenges and the potential reasons payments weren't being made known by you and more widely within the department?
So I don't recall knowing either of those two bits of data that you have just shared. On the COVID positive point, it's similar but different. I did know about one area of the country being very reluctant to roll out testing because they thought it would reveal that they had lots of people who were COVID positive and that they would therefore stop working, and intervening in that case to make the testing go ahead so that they could identify that they had COVID positive staff and those staff not work. But clearly that's a different scenario. I don't think I saw the data before that you have just described there, but I do think what you're talking about now reflects a bigger problem about the importance of that. Given that you have social care workers who are looking after people who are vulnerable to infection, you need to have a stronger cultural ethos of there being sick pay so that somebody who's on a relatively low income doesn't find they have to go to work, even though they may have an infectious illness, and that could be flu, for instance, which we know kills people in care homes every winter, because otherwise they can't afford to put food on the table. I can understand the concern of some care providers that, hold on, if we give people sick pay, well, they'll say they're sick and they won't come in. And I have heard from care providers who tell me their frustration, some of them, that their staff, they're expecting staff to come in and they don't, for all sorts of reasons. And that is a bigger question about how do you manage your workforce. Shouldn't be a reason not to pay sick pay. I think it should be paid in a sector, as I say, where people who may be vulnerable to infection are working.
Thank you. I'll just move now to my second topic, which is around vaccine confidence in the social care workforce. You refer in your statement at paragraph 363 to a letter sent to the Secretary of State in February 2021, which set out that an extensive programme of work was underway to address fears about vaccination. This included webinars for the care sector, educational materials sent to providers, and broader work to build trust amongst hesitant communities. Given what's been discussed about the complexity of the sector and the lack of operational reach into the sector by the department, do you know to what extent this programme and information was reaching care workers?
Sorry, I was trying to look up the paragraph you mentioned, but I didn't. What did you say, 363?
Yes.
Oh, yes, a letter. So to what extent was that information reaching care workers?
That programme and
Yeah.
that information.
I mean, we wouldn't have had, and as we talked about during this session, I didn't have a register of care workers, had no way of knowing, on a sort of tick box basis, had every care worker received information or not. So the approach was taken about communication of the vaccinations was a sort of broadcast look down multiple channels. This is something we worked very closely with the NHS on to try and reach all different kind of communities. We worked a lot with the care sector representatives, trying to work through registered managers in care homes who often had clearly a strong relationship with their workforce, worked with GPs. So one potential source of guidance on getting vaccinated would be somebody's GP, and GPs would literally talk through somebody, what their worries would be about getting vaccinated. So it's kind of multiple channel approach going on.
Sir Sajid Javid, during his evidence on Monday, was asked about evidence before the inquiry that many care workers felt they did not receive enough information and support about the vaccines. And he agreed that it would be worth considering a more centralised way to distribute information to care staff in any future pandemic rather than indirectly via providers. Do you agree?
So yes, and again, I think compared to say if to reach the nursing workforce, you have channels to do it because nurses are registered and you have contact details of them through that. With social care staff, we tried many ways. And I remember saying, how can I reach care workers? We created an app for staff, but it didn't have particularly great take up. So, as I'm sure you'll know, considering the organisation of representing, it's not a particularly unionised workforce. So, though I had conversations with unions at several occasions during the pandemic, there was only a small proportion of the care workforce who were actually union members, and that would be a channel of communication. So I think it would be a good thing to have a better way to communicate directly with this workforce, yes.
So is a fair summary that registration would be a step in the right direction and potentially also more mechanisms to discuss with care workers and their representatives these types of issues, and in particular to give them information about vaccines? Is that fair?
Yeah, I'm broadly supportive of that. I mean, I can see a counter-argument, which is red tape and requiring everyone to be registered and cost and all of that. But I think to weigh that in the balance of when you have a workforce who are looking after a really vulnerable group of people and taking significant responsibility to do that, it's not an appropriate thing to put in place.
Thank you, and thank you, my lady. Those are my questions.
Thank you, Ms Peacock. Mr Straw. Mr Straw should be behind Ms Peacock.
Good afternoon. I represent John's Campaign, the Patients Association and Care Rights UK. In your addendum, you appear to accept that the concerns about the adverse impact of visiting restrictions, isolation and so on, that had been raised by people drawing on care and their supporters weren't heard by some in government, and that this was partly because they weren't, as it were, in the room. In your 2023 witness statement, you also welcome, and I quote, the emergence during and since the pandemic of groups specifically representing care home residents and their families, like Rights for Residents, who helped raise awareness of the importance of visiting. Do you agree that those groups and others like them should have been better listened to by decision makers during the pandemic?
So I think, as you just allude to in that question, one of the challenges is that there was just limited groups in existence representing particularly. Rights for Residents emerged, if I recall right, during the pandemic and became a very effective advocate on visiting. The department and me personally had sort of care user groups that we did regular sessions with, whether it's in-person meetings, non-pandemic times, or lots of remote calls. And those groups included family members of people who received care. They included people who were carers, unpaid carers. They included people who themselves drew on social care support. So I did have points of contact. And TLAP would be an organisation to think about in this as well. But those were more likely to be, particularly I think particularly people who, for instance, were receiving care at home. There wasn't such a strong voice from residents of care homes, is my recollection, and that is something which Rights for Residents particularly provided. And they were one of the ports of call for getting that view as the pandemic went on, and in fact subsequently leading to the legislation which I introduced to count visiting as a fundamental standard of care, now is one of the things that CQC inspects on.
You've mentioned Rights for Residents. That they were, you met with them at least at one point, if not more, and they considered that although you listened to them, their recommendations weren't ultimately implemented. So to take an example, that they favoured the right to an essential carer and explained how that could, for example, reduce the need for highly dangerous staff movement. But although that was listened to, it wasn't ultimately implemented. Would you accept that? And if you know, and if so, can you give any explanation as to why?
Yes. So, I mean, the debate about visiting is, you get pulled in two directions on this. On the one hand, you've got those who are concerned about visiting, both care homes who are worried that visitors will bring in an infection, and in fact, some of the families receiving care who want the care home in which, say, their relative is living in to have a very strict no visitor policy. And on the other side, you'll have, for instance, families like the Rights for Resident campaigners who want a much more open visiting policy. And some people will say, I'll be prepared to take the risk that my family member might get COVID, but it's more important to me that I get to visit them. So you've got both of those viewpoints happening at the same time. Arguments going pulled in both directions. And I understand from the point of view of a care home themselves, they literally got families on the one hand saying, please stop visiting, it's not safe. On the other hand saying, let us in to visit our family. So those are difficult. And then you've clearly got the context that we were dealing with in government of a lot of people have died in care homes. And the public health advice I was given, which was very strongly on the side of infection control and minimising footfall. And the record shows me having quite back and forth with public health advisors on this, saying, well, hold on, surely we can at least allow window visiting. That's not going to be a risk to residents of care homes. And actually having to have an argument with public health advisors, say, really, I can't see how window visiting increases risk of infection to care home residents. I mean, in fact, there was a point at which that became the policy. And I remember campaigners being disappointed because at the level of restriction that was imposing on visiting, it's actually something that I fought for to even allow that. So you get these tensions going on behind the scenes. And you did a lot of back and forth about the essential care model, which I was a supporter of. But ultimately, in the policy developing process, I clearly am having to take clinical advice and advice in general on both what's seen as clinically safe and also what is seen as manageable for the care providers themselves.
And just very briefly, looking to the future, would you agree that these the views of stakeholders, like the ones I've mentioned, that they are well placed to try and help you make the best decisions, and it would be helpful for there to be a better mechanism to ensure their views are fed up?
So yes, I think it's very important to take the input of a wide range of views of stakeholders. So it's something that I did a lot of work on myself to try and make sure I was reaching out. And I think it was very helpful of the emergence of new groups. I think also, and I'm just going to pick up on one of the things you said that I had said in my statement about the importance of the people who are in the room, because one of the things I think is worth thinking of in the event of a future pandemic is making sure that you have enough people in decision-making positions beyond the individual Minister for Social Care who have a good understanding of social care and including, for instance, what makes a difference for the well-being of people who receive social care. And while in the room there was often a lot of people from the NHS and pretty much everybody has some experience of the NHS, not everybody has experience and understanding of social care. So I think that is something to be thought about for a future pandemic.
Thank you very much.
Thank you, Mr. Straw. Ms. Beattie, who's probably just behind Mr. Straw.
Good afternoon, Mrs. Waitley. I ask questions on behalf of disabled people's organisations. We know that from an early stage in the pandemic, you expressed concern about deaths in domiciliary care. And you said in evidence this morning that your most vivid recollection from the series of home visits that you did pre-pandemic was how isolated many of the people were that the care worker who took you around was looking after. You saw the SITREP on the 9th of April 2020, which you messaged Mr. Hancock about because it showed stark rises in mortality rates in care homes and domiciliary care. Is that right?
Yes.
At that stage, did the stark rise in deaths of domiciliary care recipients reinforce the need for further investigation of whether those deaths were COVID-related and hence relevant to issues such as testing, staff movement, PPE and bespoke guidance?
I mean, on the testing, because at that early stage we were very limited in the number of tests, but I think the record will show that I pushed for tests to be used across social care in care homes as well as domiciliary care, albeit that the prioritisation of how tests were used was a clinical decision in essence. So that was what dictated how tests were distributed.
But you would want to know whether the deaths were COVID-related or related to something else, would you?
I think it's important information to have in general to try and have about deaths, yes.
The ONS data then published on the 15th of May 2020 then again confirmed a very significant increase in deaths of domiciliary care recipients of 2.7 times the previous average. Now, those figures only included deaths reported to the CQC, so I presume you would have appreciated that they were likely to be incomplete. Is that right?
So I believe by that point in the pandemic I was receiving data which would have given me the full picture of deaths in social care, because by that point I believed that the double counting concern that had originally been to do with hospitals and social care had, I think, been ironed out. So I would expect that I would be given the full picture of deaths, unless there was some reason why the reports given to me unless there was some reason why I guess Public Health England wouldn't have known of all deaths. But I believe I was receiving the full picture.
Yes, I think the ONS statistics themselves explained that for domiciliary care, providers were only required to notify the CQC of a death where the person died while a regulated activity was being provided, or where the death may have been a result of the regulated activity or how it was provided. So it may have provided a limited picture of the true number of deaths in domiciliary care.
I would need to look at that rather than just having it presented to me like this.
Okay, well, that ONS data showed that the proportion of the increased deaths in domiciliary care recipients which involved COVID was lower than the proportion for care home residents.
Okay.
Bearing in mind the extent of isolation which you knew pre-pandemic that people might live in, as you've said earlier, did the fact of a lower proportion of domiciliary care deaths which involved COVID itself require further investigation of whether the increase in deaths might be due to other factors? So not only to COVID infection, but to indirect impacts of the pandemic or the pandemic response, including, for instance, people dying from a lack of basic food or hydration?
I'm trying to think back to that time and to what extent, because it feels to me like there's potentially an overlap between what you're asking me and the work that was done through the shielding programme and also the other work that was done to try and support people who, for instance, were lonely and isolated. The shielding programme was a substantial programme to try and make sure basic supplies went to people who were unable to leave their homes. I also did quite a lot of work through part of my remit was to do with volunteering and setting up the NHS responders, and some of that was to do outbound calling, which I indeed did myself as part of this, to people who were identified as isolated and in need of just some contact and to find out whether they needed any support. So that was one of the things that was put in place to try and support people who were isolated and home alone. I think that there's the reality is, and we know from the many stories, that the pandemic was an incredibly tough time for people who were isolated, particularly living alone at home, and particularly if they were shielding or unable to leave home for any reason. There's no getting away from the fact that the pandemic was a terrible, terrible time for people in those situations.
So in addition to those initiatives that you've mentioned, did it require additional focus on what, if any, guidance or changing guidance was needed to address the impact on domiciliary care recipients?
I think I would have to, if you'll forgive me, it being sort of 5 years ago now, I would have to look back at the record to see what was done in response to the data you're describing.
And I have a further question about easements under the Care Act. You refer in your statement to the aspect of easements whereby local authorities were not doing assessments and reviews. Did you understand that local authorities could invoke easements to seek to justify withdrawal of actual services contained in a care and support plan? So, for instance, cutting a home care visit or the number of and frequency of home care visits to assist someone with hygiene or with toileting.
So it was helpful probably if I take a step back at the point at which the decision was made to allow local authorities to turn on Care Act easements. The view taken there was that we're expecting a lot of people to potentially become sick with COVID, and we knew that a significant number of care workers might well be sick with COVID or isolating and unable to work. So in a scenario where you have a much reduced workforce, what are local authorities going to do? Because they probably are not, they're certainly not going to be able to continue to provide their normal levels of care to all the people they usually care for. Like, that is a obvious risk or fact that's going to happen. You've got a lot of your staff off sick, you're not going to be able to provide your full care to the full number of people who usually receive it. So the idea of Care Act easements was to have a controlled system which would involve local authorities notifying, if I recall right, the chief social worker, that they were going to have to limit and make some restrictions on care and to enable them to decide to prioritise care based on those who were in most desperate need, particularly those who, if the care wasn't provided, would, for instance, not survive. So to enable those kind of decisions to be made by local authorities, but by doing it through a formal process with the Care Act easements, so that it was communicated to the department, so that it could be monitored, so that there could be questions asked if that was continued for a very long time. That's what the Care Act easements were about.
So do I understand your evidence is that all those cuts and changes should have been reported through the easement process? Is that right?
So so the reason why I approved the care act easements was because that was a managed process. Now, what I understand, and I know because I watched some of Michelle Dyson's evidence yesterday, was in practice, and we know from the records, that only a limited number of local authorities turned on the easements, and that some potentially use what you'd call flexibilities to, which involve them therefore providing less care to people. What I found particularly startling from one of the reports I've read, it might have been in the Every Story Matters document, was that there seemed to be little in the way of consequences as observed, where local authorities didn't do the easements but did reduce their care for people. So rather than following the proper process, there's a lack of consequences, which I do think reflects a problem, which is the lack of essentially oversight and accountability for whether, and this applies outside a pandemic as well as during, so whether local authorities really are delivering on their Care Act obligations. It is one reason why I launched the CQC assurance of local authorities' delivery of their Care Act obligations, because I did not think there was enough scrutiny of whether they're doing that or not. And clearly the way that local authorities are held to account is through local elections by the members of the public in the geography of a local council voting for whether they want that council to continue to be controlled by whichever political party or not. But I don't believe that election process is very good at holding local authorities to account on their delivery of their social care obligations. I think there are many reasons why people vote as they vote in local elections. And that's one reason why I put in place the CQC process, to provide more transparency and accountability, and actually recognise when local authorities do a really good job in social care, as well as shining a light on those that are not doing such a good job.
Thank you very much.
Thank you.
Thank you, Ms. Beattie. That completes all the questions we have for you, Mrs. Waitley. I'm sure it's been a very long and tiring day. Whatever findings I make about the response of the department in which you're a minister, you personally were obviously highly alert to so many of the issues we've been investigating during the course of this module. And so may I thank you for all that you tried to do and for the way you promoted the cause of social care. And thank you very much for all the help that you've given to the inquiry. You've obviously prepared very carefully and answered all the questions very carefully. We're really grateful.
Thank you very much.
Thank you. My lady, before we conclude, may I just ask one matter of you, please? During the course of preparation for Module 6, as your ladyship knows, a number of Rule 9 requests were made of myriad witnesses. And can I invite you today, please, to publish 64 statements. They include, and I won't read them all out, but I think up on screen is going to be put a list of the 64, including the name of the witness and their organisation, their unique relativity number, and a description of who they have given evidence before. But in short, my lady, it includes the statistic agencies, government departments and other agencies, social care sector providers, representative groups and interest groups, impact witnesses from our core participant groups, and indeed statements taken from care homes across the UK. And I'd be very grateful if all 64, with your consent, could be published later today.
They can. Thank you very much. And obviously to remind everybody that I'll be bearing those statements very much in mind, as well as the oral evidence, when I come to make my findings and recommendations.
Thank you, my lady.
Thank you. Very well. We shall return. I think it's the 26th of July, is it?
21st? 21st?
21st. Can't read my own handwriting. 21st of July, when I shall be back in person at 10:30.
Thank you, my lady.